Hey there, it's great to be back with all of you. I know I haven't posted anything in quite a while. Unfortunately, the corona apocalypse hit Arizona pretty hard, so I've been working full-time in the emergency department and working in the ICU, so I haven't had a whole lot of time to get my inner nerd on. But I'm back and I am happy to be bringing you the fourth installment of Talk Nerdy to Me. Disappointingly, I still have no financial conflicts of interest, and as you may have guessed by my slides, I'm still a cat person. I also still love my mental breaks. And in my last talk, if you recall, our mental breaks featured the undeniable scientific evidence that cats are actually a liquid. So I thought it might be nice to explore a new line of scientific inquiry, demonstrating that cats are capable of simply ignoring Newtonian gravity. And I've included a few helpful force vectors to demonstrate the effect. Now, in the next 40 minutes, we're going to talk about three papers that cover a wide range of topics, from stroke to GI bleeding to appendicitis. What we won't discuss is this guy. We're not going to talk about COVID 19 because over the last year, we have all been drinking from a fire hose of information about COVID. So I wanted to talk about a few other papers that might have gone unnoticed with so much focus being on COVID. Now, before we get into our three papers, let's do a quick 2-minute update on a topic we talked about last year, vitamin C for septic shock. As you recall, in 2017, there was a big buzz about vitamin C for the treatment of septic shock, based on a case series of 47 patients published by Merrick and Company, demonstrating a staggering 31% absolute mortality benefit when a cocktail of high-dose vitamin C, hydrocortisone, and thiamine were given to patients with septic shock. Now, as you recall, it's important to note that this was not a trial. It was a before and after case series that was neither blinded nor randomized, and the authors did not recruit consecutive patients, so they were able to handpick which subjects made it into the study. So there's a huge potential for bias here. Now, in January of 2020, the vitamins trial came out, which was the first RCT to look at this. And they randomized 216 patients to receive either the same cocktail of high dose vitamin C, hydrocortisone, and thiamine versus hydrocortisone alone. But they found no benefit to the treatment. So we had a case series saying it worked and a trial saying it doesn't. Here's the update, the ACTS trial. This was published in August of 2020 in JAMA and is the second RCT to look at this topic of vitamin C for septic shock. The ACTS trial, or the ascorbic acid, corticosteroids, and thiamine in sepsis trial, pretty good acronym, guys, is a multi-center, double-blind, randomized, placebo-controlled clinical trial performed at 14 academic ICUs in the United States. Patients were randomized to receive either 1,500 milligrams of vitamin C, 100 milligrams of thiamine, and 50 milligrams of hydrocortisone versus a saline placebo every 6 hours for 4 days. Clinical and laboratory data were collected at 24, 72, and 120 hours, as well as the time of enrollment. The primary endpoint for the trial was change in SOFA score between enrollment and 72 hours. Other key secondary outcomes included the incidence of renal failure and 30-day mortality. They enrolled 205 patients and ultimately had 200 included in the final analysis. I'm not going to go into any great detail here, but suffice it to say, they didn't find any significant differences in any of their key outcomes, including change in SOFA score at 72 hours, 30-day mortality, incidence of renal failure, nor any differences in any of their safety endpoints. The bottom line is that vitamin C for septic shock doesn't seem to work. We now have 2 randomized trials with at least 200 patients each demonstrating no benefit, and the only, quote, evidence saying it works is one case series of 47 handpicked patients. So at this point, don't bother breaking out the OJ for any of these patients. All right, time for our first mental break. All right, let's move on and dig into our first topic, which is acute stroke, and talk about a few important things that have happened in the management of acute stroke. As all of you know, in 1999, the NINS trial was published, and ever since then, we have been trying to navigate the proverbial minefield of treating patients presenting to the ED with acute stroke with thrombolytic therapy. And honestly, sometimes it feels like we're trying to navigate that minefield while blindfolded and wearing clown shoes. This has been an ever evolving challenge, trying to pick the right patients, accurately assess the risks of bleeding, and weigh the potential harms versus the theoretical benefits. Originally, we only considered patients presenting within 3 hours of symptom onset, but with the publication of ECAS-3 in 2008, this window expanded to 4.5 hours. Let's take a quick stroll down memory lane. ECAS-3 was a multi-center, double-blind, placebo-controlled, randomized controlled trial performed at 130 centers throughout 19 European countries. But despite having such a robust base of sites to enroll patients, and the fact that they ran the study for 4.5 years, somehow they only managed to enroll 821 patients. That's an average of 6.3 patients per site, or only 1.4 patients per site per year. So, unfortunately, what probably happened was they had a few sites that contributed only 1 or 2 patients, and the majority of the patients probably came from a few sites that had an investigator with an interest in pursuing this. Their primary outcome was the disability score at 90 days as measured by the modified Rankin score, and they compared the number of patients that had an MRS of 0 to 1 to the number of patients with a score of 2 to 6 in each group. They enrolled patients presenting between 3 and 4.5 hours after symptom onset and randomized them to receive either thrombolytic therapy or placebo. I know most of us could probably recite this in our sleep, but just in case anybody needs a reminder, here is the modified Rankin score. I do think it's a bit odd that they picked a score of 0 to 1 as their good functional status outcome. Most trials looking at functional status use an MRS of 0 to 2 as a good outcome, because with a score of 2, you're still able to manage your activities of daily living and live independently. But for whatever reason, they lumped all the people who could still walk and manage their own activities of daily living, albeit with some deficits, in the same group with patients that were bedbound requiring 24/7 nursing care. That just doesn't quite seem like it's a fair comparison, but that's how they set up the study. In the intent to treat analysis, they found that 52.4% of the patients in the thrombolytic group had a modified Rankin score of 0 to 1, as compared to 45.2% of the placebo group, with a confidence interval from 1.02 to 1.76. Based on this, the authors concluded that TPA demonstrated a statistical benefit over placebo, and this became the literature basis for expanding the window to give thrombolysis from 3 to 4.5 hours. You're probably wondering, why are we talking about a 13-year-old study? Well, in May of 2020, the BMJ dropped a quiet little bomb on the stroke world when they released this paper, a reanalysis of the ECAS-3 data. And spoiler alert, the findings of the reanalysis don't support the same conclusions reached by the original authors. Why did they decide to reanalyze the data? Much like the reanalysis of NINS that was published 14 years after the initial trial was published, these authors noticed that there were significant differences between the groups being studied. When NINS was reanalyzed, the authors took into account the fact that the placebo group was actually sicker than the thrombolytic group, and found that this is actually what accounted for the difference between the groups. Similarly, the authors at the BMJ wanted to know if the baseline differences between the groups in ECAS-3 might actually be what accounts for the benefit being reported. There were two variables that demonstrated significant baseline differences between the groups in ECAS-3: the NIHSS score at presentation and history of a prior stroke. The NIH score at baseline was lower in the thrombolytic group with a mean of 10.7 than it was in the placebo group with a mean of 11.6. And this difference was statistically significant, meaning that the placebo group was a little bit sicker than the thrombolytic group. Since the degree of initial injury is one of, if not the strongest predictor of how well you're going to recover after a stroke, it's understandable that this could certainly bias the results. Secondly, patients in the placebo group were twice as likely to have had a prior stroke than the TPA group, 14% in the placebo group versus 7% in the thrombolytic group. They looked at 7 different outcome measures in their reanalysis: symptom-free status at 90 days, disability-free status at 90 days, dependence-free status at 90 days, mortality at both 7 and at 90 days, symptomatic intracranial hemorrhage at 7 days, and change across that MRS spectrum in an ordinal shift analysis. Remember this ordinal chart looking at the MRS scores for the ECAS-3 patients? Well, when the authors of the BMJ paper attempted to recreate the results of the original paper, they discovered that there was an error in reporting data on one patient. The error resulted in this patient being incorrectly categorized in the good outcome group of patients with an NIHS score of 0 to 1 at 90 days when the patient's actual score was 2. That single patient's change in outcome was enough to make the original analysis no longer statistically significant. Likewise, they found that if you used an outcome measure that I think most of us would find more reasonable, categorizing a good outcome as a modified Rankin score of 0 to 2 instead of 0 to 1, that the statistical benefit they report also disappears. One other interesting side note I'd like to mention that kind of helps speak to the validity or lack thereof of ECAS-3 is the IST-3 study. IST-3 is the largest randomized controlled trial of thrombolysis versus placebo to date, and this was a negative trial that did not demonstrate a benefit. Despite the fact that its primary outcome was negative, it was published as a positive trial based on some secondary outcomes. But that's a whole nother can of worms we're not going to open right now. What I think is relevant to this discussion is that IST-3 looked at thrombolysis up to 6 hours from symptom onset, and they did a pre-planned analysis of patients presenting from 0 to 3 hours, from 3 to 4.5 hours, and from 4.5 to 6 hours. When we look at the 3 to 4.5 hour group that mirrors the ECAS-3 population, IST-3 enrolled 1,177 patients in this time window, more than were included in the entire ECAS-3 trial, and they reported no difference between the groups when they were analyzed using a 99% confidence interval. Now, using a 99% confidence interval is a little odd since the conventional reporting approach is typically to use a 95% confidence interval. What's interesting about their choice to use the 99% confidence interval is that when you look at their analysis with the standard 95% confidence interval, it turns out that the placebo group did statistically significantly better than the thrombolytics group, meaning that TPA was actually harmful in the 3 to 4.5 hour group. So even though this is a larger trial with more patients than ECAS-3, everybody just ignored this data when the time to make the guidelines rolled around. This is the conclusion reached by the authors of this reanalysis of ECAS-3. Not surprisingly, they question the validity of the results in the original paper and are recommending that the guidelines we are currently being told to follow be adjusted given that the data do not support the author's original conclusions. This was taken directly from the current AHA guidelines for the management of acute stroke. And this is the section that discusses administration of thrombolytics to patients between 3 and 4.5 hours after symptom onset. As you can see, it literally says right here in the guideline that the entire literature basis of this recommendation is from the ECAS-3 trial data, because to date, ECAS-3 is still the only randomized controlled trial that has reported a benefit in this time window. If this is true, now that the reanalysis of this trial with improved statistical methods has demonstrated that there's no benefit, then the entire literature basis of this guideline has just fallen apart. So, where are we going? This slide, I'm going to warn you in advance, is entirely editorial on my part. And I think it's only fair to point out that we are entering a completely evidence-free zone with this slide. So the endovascular trials have clearly demonstrated that time isn't really the variable that matters the most when considering therapy for acute stroke. What really seems to matter is having the right combination of a small infarcted core, a larger, potentially salvageable ischemic penumbra, and a robust collateral circulation. If you're lucky enough to have the right combination of all of these, you are much more likely to do well, and you are much more likely to benefit from something like an endovascular intervention. If this is true, then the same should be true for patients that we give TPA to. The data we have so far regarding thrombolysis, at least based on my understanding of the data, demonstrates that giving thrombolytics based on a time window just doesn't work. But the question I have is, are we just doing it wrong? And would it work better if we had a better way to pick the right patients? I feel like we've all been so stuck on this concept of time windows and time is brain for such a long time that it's kept us from asking the right question. How can we pick the patients that are more likely to benefit, less likely to be harmed, and selectively treat them? Now that CT perfusion is becoming more widely available, I'd really like to see some studies that shift away from this whole concept of time is brain and start to move to a penumbra is brain mindset and start utilizing perfusion imaging to help us make this decision on who is a good candidate and who isn't. The bottom line, stroke sucks. So eat your veggies, go for a run, and keep yourself healthy so this never has to be you on the other side of that bag full of TPA. But for now, we'll just have to see where that road leads. So our bottom line for this paper, the reanalysis of ECAS-3 demonstrates that the data in this trial do not support giving thrombolytics between 3 and 4.5 hours. So what do we do with this at the bedside? Frankly, that's a really good question. I would argue that this section of the guidelines needs to be revised to reflect the reanalysis of the ECAS-3 data. But let's face it, we've all known for a while now that the data supporting thrombolysis for stroke has never been particularly robust. Both NINS and ECAS-3 have both been reanalyzed, and in both cases, the reanalysis demonstrated that the conclusions published by the authors in the original trial were not really that well supported by their own data. But as long as there is money to be made giving the drug and there are careers to be advanced, I'm just not optimistic that we'll see much movement from any of the major societies or from the drug manufacturers on this. This unfortunately makes things very challenging for the individual practitioner at the bedside. Even though we understand the data doesn't really support the use of thrombolysis the way we're doing it, it's difficult to practice this way when there are guidelines from major professional societies and 2 decades of standard practice telling you that you should give this drug. A change like this needs to occur at least at the institutional level to create a standard practice with written policies in place supporting your practice. But either way, we still need to know about this literature, so at the very least, we can temper the expectations from our patients and make sure they know that when thrombolysis is offered, it is not a miracle drug. Time for a mental break. All right, let's leave neurology and let's move on to talk about GI bleeding. Last year, we discussed CRASH 3, and this year, we're going to talk about the HALT-IT trial, which was published looking at the use of tranexamic acid for acute GI bleeding. This was published in The Lancet in 2020 and was an impressive effort that ticks all of the boxes. It's a multi-center, placebo-controlled, double-blinded, randomized controlled trial performed at 164 hospitals in 15 countries and asked whether giving tranexamic acid to pretty sick GI bleeders would improve outcomes. The patients they enrolled were mostly of moderate illness, but they did include some pretty sick folks. To be included, the GI bleed had to be severe enough that the clinician felt that there was a risk of death from blood loss, signs of hemorrhagic shock, suspected need for transfusion, or need for urgent intervention, such as endoscopy, surgery, or some kind of interventional procedure. All of the patients enrolled were adults based on the age of consent in the participating country, mostly 18, but in a few places it was 16. They enrolled 12,009 patients and ultimately analyzed 11,937. They lost a few for various reasons. Consent was withdrawn, the patient was discovered to be ineligible after randomization, blah, blah, blah. I won't go into any great detail, but suffice it to say that the randomization worked really well and the groups were really well balanced. Their primary outcome was death due to bleeding within 5 days of randomization. Now, I want to point out that they changed their primary outcome after recruiting over 10,000 patients. The trial was originally designed to look at all-cause mortality, and then they changed it to death due to bleeding at 5 days because they felt that there were too many patient deaths from non-bleeding complications in the study. Now, patients don't care whether they died from bleeding or died from something else. They care whether they died. So, disease-specific mortality is an imaginary statistical concept that has to be adjudicated, making it a less accurate outcome measure. So, I obviously think it was a bad choice. But they did at least disclose that in the paper and stated their reasoning, so I give them full props for being open about it. They looked at dozens of secondary outcomes as well, and I listed all the ones that I thought were important here. Their primary outcome was death due to bleeding within 5 days, and there was no difference between the groups for this outcome. There was also no difference in all-cause mortality, which is arguably an even more important outcome measure. In fact, there was no mortality benefit at any of the time points included, nor was there any difference based on any of the other subgroups they looked at: upper GI source, lower GI source, variceal bleeding, or non-variceal bleeding. All right, so if mortality was no different, what about other outcomes? If TXA reduced the need for interventional procedures, it may still have some value, even if it didn't reduce mortality. Unfortunately, that was not the case either, and TXA did not appear to have any effect on how many patients needed a procedure, including endoscopic procedures, interventional procedures such as intravascular ablation, or need for surgery. Okay, how about transfusion? If tranexamic acid could reduce the need for blood products, it could still certainly be of value, especially in resource-poor environments. Again, TXA disappointed us as there was no reduction in the number of patients that required transfusion. They also looked to see if there was a reduction in how many units were transfused, and TXA had no impact on the number of units given. Anytime you do a trial investigating a drug for potential benefit, you also have to consider the possibility that there might actually be some harm. For most of the adverse events they looked at, including MI, stroke, renal failure, respiratory failure, and a partridge in a pear tree, there were no differences. but they did note a statistically significant increase in the number of patients who developed a venous thromboembolic event and in patients that had seizures, raising concern that there could potentially be a signal of harm to this treatment. So, why didn't it work? In CRASH 2, it was noted that TXA works the best when given early. But with GI bleeding, we don't actually know how long the bleeding has been going on. All we really know is when the patient says they started to feel bad, and the bleeding could very well have been going on for quite a while before the patients became symptomatic. On top of that, only 16% of the patients in this study presented within 3 hours of becoming symptomatic, and the mean time of symptom onset to randomization was over 20 hours. So it's likely that we're not ever going to get to these patients in an appropriate time window for TXA to have a meaningful effect. The majority of GI bleeding included in the study also ended up being in patients with underlying liver disease, with nearly half of the bleeds being variceal. Now, varices bleed with a lot of force because there's a lot of pressure in the venous system, specifically the portal venous system. The basic mechanism of TXA is such that it stabilizes clots. But if you're bleeding so quickly that clots never form, it probably isn't going to have much of an effect. That being said, they didn't see much of a treatment effect in the subgroup of GI bleeds not suspected of being variceal either. The bottom line, TXA doesn't appear to improve mortality in patients with GI bleeding, and there may be some potential harms. At this time, I can't really endorse the use of TXA for GI bleeding. Time for another mental break. All right, let's move a little further along the GI tract now, and let's talk a little bit about appendicitis. This trial was published a few months ago in November of 2020. This is not the first trial to compare antibiotics versus surgical appendectomy for acute appendicitis, but it is currently the largest RCT that addresses this question. It's a pragmatic, multi-center, non-blinded, non-inferiority trial performed at 25 centers in the United States with consecutively enrolled patients to avoid any selection bias. So we're talking about a pretty well done trial. That it was non-blinded is completely understandable in this case because it's pretty hard to blind somebody to getting surgery versus getting antibiotics. They had 1,552 adult patients randomized, where 776 received surgical appendectomy and 776 received antibiotic therapy. Patients in the antibiotic group got at least 24 hours of IV antibiotics, followed by a 10-day course of oral antibiotics. And the others received surgical appendectomy, where both laparoscopic or open appendectomy were allowed. But as you might imagine, 96% had a laparoscopic procedure. Their primary outcome was 30-day health status as measured by the European Quality of Life 5 Dimensions questionnaire, which I had never heard of before. But it's a scoring system over 5 dimensions of health status: mobility, self care, usual activities, pain and discomfort, and anxiety and depression. Each dimension has 5 levels from no problems, slight problems, moderate problems, severe problems, and extreme problems. They also looked at multiple secondary outcomes, including patient-reported resolution of symptoms, need for appendectomy in the antibiotics group, complications through 90 days, frequency of return ED visits, missed workdays, and serious adverse events. Now, it's important to note that the patients included in this trial were those that you and I would think of as uncomplicated appendicitis. This trial did exclude some patients, namely those with septic shock, diffuse peritonitis, recurrent appendicitis, evidence of abscess or phlegmon, free intra-abdominal air, or those who had evidence of neoplasm. Another interesting thing about this trial, and unlike any of the other previous trials looking at this topic, is that they didn't exclude patients that had an appendicolith. 414 of the patients in this trial actually had an appendicolith. The authors included a pre-specified subgroup analysis of these patients to see if the presence of an appendicolith made any difference on the rate of success. So, for their primary outcome, there was no difference in the EQ5D score at 30 days. So, wah, wah. When you looked at the cohort overall, there was also no significant difference in the time to resolution of symptoms either. So far the antibiotics are looking pretty good. Unfortunately, things didn't look quite as good when we start looking into the adverse events. At 90 days, the antibiotic group had twice as many return visits to the emergency department, and 5 times as many patients needed recurrent inpatient hospitalization as compared to the appendectomy group. When they looked at how many patients in the antibiotic group needed an appendectomy, about 11% failed their initial management and went on to need appendectomy during their initial hospitalization, which seems pretty reasonable. By 90 days, almost a third of the cohort had returned needing surgical appendectomy. If an appendicolith was present, 41% needed surgery by 90 days. When you excluded the patients that had an appendicolith, that dropped to 25%, but that's still a quarter of the cohort that needed subsequent surgery and ultimately failed conservative management. Things get even more interesting when we look at that pre-planned subgroup analysis of patients with an appendicolith. Overall adverse events were statistically more common in the antibiotic group overall, but this difference was largely driven by the patients with an appendicolith. The frequency of adverse events in these patients was over 5 times that of the group without an appendicolith. Patients treated with antibiotics were also twice as likely to have a perforated appendix at the time of surgery when initially managed with antibiotics alone. And that was also largely driven by patients with an appendicolith, as 61% of patients in the antibiotic group had a perforation at the time of surgery versus 24% of patients who got primary appendectomy when an appendicolith was present. Patients without an appendicolith had almost identical rates of perforation between the groups at the time of surgery. So the bottom line, if you look at the primary outcome alone, this trial found that an antibiotic-only strategy was non-inferior compared to primary appendectomy. But 3 in 10 patients had undergone appendectomy by 90 days, and there were twice as many more return ED visits and more than twice the complications in the antibiotic-only group. On the flip side, the patients in the antibiotic group were on average able to get back to work a couple of days sooner. At the end of the day, it kind of depends on your point of view. A treatment that a third of people fail isn't a great treatment, but you could also look at it from the glass is half full point of view and say that, well, 2/3 of the people avoided the need for an invasive procedure. I think one of the biggest limitations with this paper is that they only followed patients out to 90 days. Now, the authors reported a reasonably good reason for that. The authors were trying to get this data out there to help with decision making during the COVID pandemic, when everybody was getting crushed and there was concern about whether there would be hospital capacity to get patients to the OR if needed. Of note, patients with an appendicolith are at much higher risk, more than 5 times the rate of complications and a 3-fold greater risk of perforation at the time of surgery. So in patients with an appendicolith, an antibiotic-only approach may not be the wisest tactical maneuver. Ultimately, this is a decision that we are going to be making in conjunction with our surgical colleagues. Time for our last mental break. All right, well, that's all I have for you today. I hope you're all safe, healthy, getting vaccinated, and having a better year than last. Take care, and we'll talk to you soon.